Good morning, everybody, and welcome to the Health and Adult Social Care Scrutiny panel. We have a couple of apologies from the panel, Councillor Zaman and Lynn, one of the counties. So, to the agenda, minutes of the previous meeting in February have been circulated. Are there any points anybody wishes to raise on the minutes themselves? No? Do you accept them as a true record? Yes, okay, thank you. There's just one item that on ambulatory care we were looking to work with Wakefield to see if Wakefield wanted to work with us on ambulatory care services, and we're discussing with Wakefield how that can happen. Okay, so item 4. No, I've missed several out. Item 2, interests. Does anybody have any interest to declare? No? All debates are in public, so we agree the public can be admitted to the meeting, yes? And so now we're on item 4, which is the Kirklees Integrated Wellness Model. And you're here this morning, Keith and Carl, to talk to us about the model because you're about to go into phase 2 for your service transition period, I believe. So do you have an introductory that you want to say, bearing in mind that we will have read the report and that we will have plenty of questions as usual? Okay, thank you.
Good morning. I was just going to introduce myself and hand over. My name's Keith Henschel. I'm Head of Health Improvement with the Kirklees Council Public Health Team. I'm Senior Responsible Officer for both Wellness and the 0 to 19 Healthy Child Programme. Carl, and apologies from Jill. I think she's sunning herself sensibly somewhere warm and dry currently. Carl and Jill have obviously put together the report, hopefully, to address the questions and issues you'd raised last time. So really it's just open to any further questions on clarifications on the report that they've presented, which Carl will do his best to answer, bearing in mind that to some extent we don't have the operational detail as yet, not least because some of that still has to emerge because we're wanting to co-produce that with the staff teams once they're sort of up and running. So, over to yourselves really for any further questions and clarifications.
Can we just clarify first of all where you are? So you've been engaging with partners and service users, etc. But what you just said is the model itself you want to put in place with working with staff. So have you no further engagement with service users on the model itself? Just for clarification, and we'll open it up to questions.
Not directly at this point, because we've built on all the previous engagement that we've had with service users and the public so far to work up the specification.
Yeah, on paragraph 1.1, it refers to offering a strong opportunity for co-production with service users and stakeholders. Presumably that's in the period from 1st of April onwards. Could you just clarify how that will actually take place? How will service users get involved in the co-production process?
To some extent, that's still to be determined and worked up. However, we envisage that we will build on existing interaction with service users that we have from service users accessing existing services, how they're configured, but also using our links through Community Plus. So as you're aware, that service sits under Jill Greenfield as well. So we want to use some of the staff officers and our links into the community to build some of that insight as we go forward. But a lot of it will take place in terms of existing service provision.
Perhaps a bit more detail if possible. I wonder whether, for example, it's intended to have a service user panel that's a kind of standing panel that you'll be able to refer back to as the process goes on, in addition to consulting with specific organisations in the voluntary and community sector? Thanks.
Yes, that's a really good suggestion, and we'll explore different options and approaches that we can utilise, but that's a good suggestion we can take on board.
Just going back to something you just said in terms of using Community Plus, and it's obviously then includes the community already. From my understanding, Community Plus are still in the process of mapping out, specifically in the north. I know that Jill and her team have mapped out into the communities and lakes and whatnot. So if you're trying to go and live in April, how does that all fit in? Because from my understanding, Community Plus is not operational in that sense. Sorry, I know Jill's not here, but...
Yes, I mean, you're quite right. Community Plus is still finding its feet, and obviously I can't answer that in detail on behalf of Jill, but there are some links emerging in terms of work that's on the ground, and it's kind of how that runs hand in hand. So those opportunities where there is interaction with the community, with the workers as part of Community Plus, currently, and as it develops further, we want to make best use of that. I mean, just a point of clarification in terms of the go live kind of definition that's been in previous papers. I mean, to some extent, we have been put back in terms of when the model will go live because of the processes that we have to go through within the council of staff moving into their new roles. And the interview processes that goes on behind that. So the go live date really is more of a date that we start to transition. So it's about managing caseload of existing services, how we work up the detail that's in the operational model that was sent out as Appendix B with the documentation. So our actual go live date for the public, where we're in operating new service and it will be rebranded, is the 1st of September. So that's just that point of clarification. So in between now and then, that gives us even more chance in terms of that ongoing dialogue with the community to shape some of that up.
Period from April to September, when you want to go live with the community, with people outside of the office. I have seen very little in the report itself to actually say this is how your structured communication will be, to actually let the communities and people know of the services that you will be providing, or the changing services that's obviously what we'll be giving out.
Yes, and take that point, and we will firm that up as we go along. Thank you.
Can I just say that I think it's disappointing that you are still at this point as far as working this particular strand of work, because I seem to remember that we were at the same position last time you came. So I think it does seem disappointing that there's nothing firmer that you can talk about. I realise Community Plus aren't represented here today, but there's nothing firmer in that work that appears to need to be done at this point in time. So really, you've got April to September, haven't you, to sort of transition between one set of services and the new model. You would have thought that you would have needed the Community Plus side of things in definite place by April, so that for a smooth transition. So it does seem disappointing. Peter, you wanted to come in.
Yes, I wondered, please. It's really going back over old ground, but it might help us if we could clarify who users are. Because on the one hand, and we've learned from colleagues previously that this is very much about health promotion and disease prevention. And I wondered how much that was the case. And how much has it got to do with better management of pre-existing mortalities and pre-existing problems? So, really, is it about helping us all live forever? Or is it about helping us cope with the difficulties we've already got? So it's this clarity as to whom a user might be.
It's a bit of both. I mean, how services are currently configured, certainly around how we use this resource, I think the focus is more on waiting for people to develop long-term conditions, multiple long-term conditions, become ill, and then we do something about it. But we have a whole range of insight and intelligence that shows us that people are at risk of developing certain long-term conditions earlier on. So it's how do we create healthy environments earlier on? How do we target those who are at risk earlier and provide some of that support, some of those interventions earlier? How we work with them holistically. But the way of working will be, in many ways, identical to those people who have existing long-term conditions and comorbidities, because it's about, yes, how they manage their conditions, but their broader health and well-being, the things that are driving their health behaviours, their unhealthy behaviours that they may be adopting as part of the long-term conditions that they have, and some of those social determinants around that we want workers within the wellness model and services as a whole to put greater focus on working together on.
Thank you. Yeah, thanks. That really brings us back to this whole business of what is wellness and what is well-being. Because well-being implies that you're financially comfortable. And when you get into those socioeconomic determinants that you've just referred to, I just wondered how your approach is going to tackle that.
Well, we know there's a whole range of different socio-economic determinants. You pointed out finance there, being in employment, being in good employment, but it's starting with where people are at. There's a whole range of factors. It might be learning and skills. We might be trying to engage with somebody who's never worked, and it might, a key focus of the interaction with an individual like that who comes into contact with a wellness model, whilst we're looking at their broader health and well-being, if we understand where that person's at, it should naturally emerge that things like opportunities to stuff in the community, resources in the community around learning and skills at a very basic level might be a key part of some of the solutions for that individual, and how a wellness worker can support some of that by working in partnership with other professionals and other colleagues, as well as looking at some of those more healthy needs and issues at the same time.
Just one last one. I just wondered whereabouts in the literature, either international or in this country, on what are you basing your approach to change people's behaviour and lifestyles?
The whole concept of the wellness model is rooted on the Marmot Health Inequalities report. So the whole rationale, the evidence base that advocates that we need to be addressing the social determinants of people's health and health behaviours is the key evidence base underpinning the whole wellness approach. Yes, yeah.
Just a question on Appendix B. There's a reference there to in Figure 1 on our page 41 to the core service. It says for implementation from the 1st of April 2019. So just coming back to the previous discussion about from April to September, it's a sort of transition period. This is talking about implementation of the core service from the 1st of April. Does that date still stand, or is that effectively pushed back to the 1st of September? And also in the little box underneath, in the referral processing, it talks about all being done in so many working days, but that's not specified, which is actually quite a key factor.
Yeah, I think that's a little bit misleading as a typo, as a previous iteration that we need to change and make that clear. If you refer to other sections within the documents, you can see where we've changed it to the September date in terms of going live, so we do need to make that clearer. But I would just point out, in terms of transitioning and that happening between now and September, it may be that small elements start to emerge and develop as part of that, you know, of what it will look like in September. So it might not be a case if we get to September and it all goes live as it is then. Some of it may emerge earlier between now and September, if that makes some sense.
Yep. It's on page 35 of our report. It's referring to your aims, really, and you summarise those in terms of longer term, medium term and short term. I just wonder how progress against those aims will be measured. They don't look very measurable to me.
Behind the scenes, we're doing a lot of work with partners and the organisation that we've brought in to support this design and implementation and the transformation, an organisation called Big Life, who we've referred to in previous papers. We're doing a lot of work around performance measures and outcomes that we want the service to achieve, and over a period of time. And one of the things that we are unpicking at the moment is clear service objectives within the first year in relation to some of these kind of broader headline statements here. So we are on with unpicking some of that. As commissioners, we've already got things in mind that we want to see quite clearly in the first year, and some key service deliverables. But that will be added as an appendix to this document as we work that up in the coming weeks.
So do you have a sort of target date for when that performance framework will be in place?
We would want it as we start in September, so as the service officially goes live, we would want key service performance measures to be in place by then. But what we've discussed with Jill, as the head of service of the service provider, is that we need to allow some flexibility in terms of you know, the service starting to emerge. You know, it's key things that we want to measure and keep track of and make sure that they're being delivered, but we don't want to overburden Jill and her colleagues, especially in the early stages as we're working through some of the transformation, and we want the service to be designed and emerge around that.
So is there a series of key targets for the transformation period, the April to September period, including the work that the Big Life Group is doing?
We've got some key performance measures and deliverables specifically for the work that Big Life are doing as part of that individual commission. I think we've shared that with Scrutiny previously, so we're holding them to account on that. So far they've delivered on what we've asked for. We're happy with their performance, but as you say, in between April and September we will have some key performance measures that we want to keep an eye on, and then from April onwards, in the first 12 months, the service performance measures and outcomes will be agreed, and you know, we will be performance monitoring that on an ongoing basis with Jill and her colleagues.
So will those key performance targets for the transitional period, will they be in place by the 1st of April?
Yes, it might need some firming up. I mean, we have got some of those. We've got a framework already in place in terms of the key performance measures, and we're just kind of ironing out some of those in partnership with Big Life. So yes, we will have those in place. We can have those in place by 1st of April.
Yes, my question is around volunteers, and in relation to Appendix B, the operational model, and your short-term plan. It actually comes across when you read it as being more like a wish list, And I just wondered, it's a shame that Community Plus aren't represented here today, because you've got no, how do we know that you're going to have these volunteers in place to provide the activities and offers? You talk about person-centred interventions, connecting people to their own resources and wider assets. Again, have you actually got have you got evidence that or there's no evidence here to suggest that you've got those measures in place at all? Again, the same with volunteers, and I just wondered if you could provide me with some figures or progress on that, please.
We do have quite a big existing volunteer base with existing services, so the PAL service as it is at the moment, expert patients programme, and also with the health trainers. So we've done some engagement work with those volunteers, right through the process of when we worked up the specification for the wellness model, and we've engaged with them and talked with them on how they envisage continue to be a volunteer. Do they want to be a volunteer in terms of what we're designing here? What's their views on what we're designing? And we've had some positive feedback. We've had commitment from volunteers that they still want to carry on. We've talked about how there's other opportunities to get involved in volunteering as part of this. So building on how they're supporting existing services. And we've also made it very clear of our value of volunteers and how we need to support them as we would support paid staff in terms of their personal development. What we can offer them, the opportunities, what they want to get out of it. This document probably doesn't do justice to the work that's going on behind the scenes. So some of these statements here are quite high-level strategic statements. So I appreciate how it reads as a bit of a wish list, but all I can do is reassure you that we have got a project plan as part of the project board around this and specific work streams, and engaging with the volunteers on an ongoing basis is clearly in view, and we're looking to address that as part of designing this model.
Can we just clarify, because you've said on page 36 of our papers you've got PALs, Active for Life, health trainers, expert patient, etc. Can we just clarify, these services that run, and some of them run in the community and provide a service that people can go into now, will these services be continuing under the wellness model, or will there be not the service as people know it now at all? Are you replacing it completely, or are you taking it away completely, or are you, because you talked about the volunteers working in another area, so do we take it then that some of these will no longer exist after September?
Yes and no, I guess is the answer, in terms of we're using all of that collective resource to transform a new service. However, there's bits of it that will still be similar. So, for example, the PALS provision, which is an exercise on referral scheme, we've committed to carrying on with an exercise on referral scheme, certainly in the early period, and we will evaluate that. But it will be refined to bring it more in line with nice guidance around, the effectiveness and how exercise referrals should be delivered. So through the work that we've done with Big Life, we've identified some shortcomings in terms of how our exercise on referral scheme could be delivered more effectively. In terms of the health trainers, yes, that won't be delivered as it is at the moment. There'll be elements that will be similar, but it won't be the same. It'll be in the context of the wellness model as a whole. So that broader approach, that more holistic approach, and the idea, is going back to the original rationale, is we don't have multiple services, we have a single point of access where we have that coordination and people are offered interventions accordingly.
Thank you. Three things, please. One, going back to your criteria for success. You mentioned Marmot, Aitchison before him, going back as far as Black. They all use a lot of epidemiological data. And whilst I can understand in the short term your indices of success will be setting up services and getting uptake, do you have any long-term intentions to sort of look at incidence and prevalence of things that might have been modified?
Absolutely, and that will be a measure of our success in the long term. If we start to see, a reduction in obesity levels, in the number of people with long-term conditions, some of the inequalities in those outcomes, more people physically active, people's mental and emotional well-being, people feeling more in control of their life, their health and well-being out in general. We already, as part of our public health function, we monitor those things on a population level currently, and give them great scrutiny and horizon scan for problems and issues that are emerging. So it's well within our gift to keep an eye on those things on an ongoing basis and ultimately in the long term. I mean, we've always said that this is a transformational programme, 5 years, 10 years down the line. But crucially, some of those things I've just described there, on a population level, the wellness model can only play a relatively small part in. It requires a system approach to that. So it's why a key part of what we're aspiring for with the wellness model is how it, and one of the reasons why we've called it a model, not a service specifically, is how it works with other partners and agencies, how it creates community capacity, how it increases access to existing resources delivered by the third and voluntary sector. We build confidence and self-efficacy for people to access those things. So absolutely, all the things you described will be our measure for success in the long term.
Yeah, and that really brings me to sustainability, because there are many examples in the literature, you know better than I do, where there have been quick-fire campaigns, and once they've lost their intensity, it all evaporates. And really on the sustainability notes, I just wondered how you were working with the new primary care networks and how easy or difficult it is to sell this to GPs.
Absolutely, that's really one of our intentions. Primary care networks are a key partner. It's very early days, as I'm sure you're aware. Primary care networks are emerging themselves, so we have it in view. Myself, others, Keith, Emily, other public health colleagues, are making inroads, building relationships. And don't forget as well, because each of the primary care networks are their own individual places and have their own individual needs and assets and starting points. We need to take account of that in terms of the conversations and how we engage with them. But the early conversations that we're having, Emily, our public health consultant, is working very closely with Steve Brennan, one of the senior officers involved in the primary care networks. They have all that in view, and we really want to build and develop that.
Yeah, I think that's encouraging, because if you're doing something that empties surgeries, you have allies. Just one final point, please, which is really value for money. That people often say that these sorts of health promotion activities save the health service money in the long run. I don't know if you hold to that view, but I mean, I put to you that you actually finish up being more expensive to the health service, because you cause us all to live that much longer, and then when we do become ill, we've got multiple pathologies. So really a comment on how you're going to achieve value for money.
Yeah, I guess there's some truth in that. I guess I think the key for us is people living healthier for longer. That's what we're trying to achieve in all this. You know, it's not inevitable that people need to age and be unwell and develop long-term conditions. We can keep people well for longer, happier for longer. So trying to decrease that burden on the whole system, you know, health and social care. But yeah, it could be a possibility.
Yeah, just a question around, it's again on Appendix B, paragraph 3 on our page 37. So the heading there is why are we changing? And then there's a list of bullet points which form your vision. What I'd like a bit of clarification on is which of those bullet points aren't currently being implemented. So just taking the first one, person-centred support, as I understand it, that already exists. So I'm not sure the extent to which those bullet points explain why there's a need to change.
What we've uncovered is some of this is happening already within existing services. Some of it isn't to the extent and to the level that we're aspiring for. We feel that there's plenty of room for improvement. The term person-centred and a holistic approach, you know, it's something that we feel that you can continue to get better at. We feel that sometimes, and this has been uncovered through our colleagues from Big Life who have been observing some of the sessions within the existing services to get an idea as to the extent of how much this is happening or not in relation to what we're aspiring for. And their feedback has been, you know, it's variable. There's lots of good stuff that goes on in existing services, but in terms of truly working with people holistically, seeing their broader social circumstances, not just in the confines of your specific service agenda. So, for example, if somebody comes to PALS, they're specific. It's easily for that member of staff to fall in, well, they're here, I'm here, my job is to make you more physically active, and, you know, I will prescribe that. There may be elements of, you know, a person-centred approach, but we feel that it's not being done to the extent that we would like it to be done, and the opportunities of skilling staff up to have a broader skill base, and as I say, see the broader social determinants of an individual in front of them, and then kind of more technical skills around what we call motivational interviewing. We feel that there's quite a big scope there to develop that further.
Yeah, just not sure whether, having said that, it requires a new model to be implemented or better implementation of an existing model.
Again, it goes back to the underpinning rationale and the evidence base of the wellness model as a whole. You know, the person-centred bit of it, very important bit of it, working holistically, but it's not just about that as well. It is about, you know, individuals don't live in isolation in terms of a specific condition or a specific issue. How we can make the whole process a bit more seamless and easier for people. We know that people have multiple unhealthy behaviours, so rather than go to individual services, how can we work with people in, you know, kind of one process, have that wraparound support, coordinate that better, how we increase some of the capacity in the community, so it's not just about the services and interventions. I mean, at the moment we have a process whereby, you know, if a patient accesses primary care, you know, and they smoke, they're overweight, they have unhealthy diets, they will be dealt with in individual ways and go to 3 different services. So part of our rationale is to how can we make that more effective? How can we make it so that that individual is only telling their story once? How can they build a trusting relationship with an individual? And there's also something about the inequalities that we're trying to tackle. And as I touched on earlier, the starting point of people's lives. You know, a lot of the people who we want to engage with and target going forward, who are at greatest risk, who are disenfranchised, aren't accessing primary care, aren't accessing mainstream services. So how can we work in a different way and access those people in the community? So it's some of that broader stuff that's part of the rationale for the model as a whole, as well as, you know, the person-centeredness and other stuff you've referred to.
So you just said something there about people not accessing primary care, and so you want to engage with those people. I don't actually see anything in this paper of ways of people engaging with these services who wouldn't engage with primary care in the first instance. Because you said your referrals can be self-referral or through your GP or through the mental health or healthcare, HCP, which I take it's healthcare partnership or whatever. But if people are not engaging with those bodies and wouldn't self-refer anyway, how are you going to engage with them? Because on page 45, what you're saying is there's a strong argument to have services focused in only a few places, so Dewsbury West, Croslandmoor, Ashbrown, Dalton, and then Backley West. So how exactly are you going to engage with people to bring them into this service if there's nothing here that tells us that?
Yeah, I appreciate that level of detail isn't described there. But just to reassure you, it is very much part of how we envisage this operational model playing out. And our thinking, our conversations, again, is going on behind the scenes around this. We've been working very closely with a range of key partners, key organisations, so Kirklees Neighbourhood Housing, third and voluntary sector organisations who do have access to some of the client groups who we want to engage better with. And we've been having conversations, looking at innovative ways of how staff could work jointly together, how we can build on their links that they have in the community with some of these key groups. We've also, we've already mentioned Community Plus and the opportunities that has in terms of us engaging with the community. But I think, you're absolutely right. There's no one silver bullet here. There's no one right approach, and we need to build that up as we go along. We have a strategy and partnership group, and that's the forum where all key partners and agencies come together, and we are specifically looking at this. How do we join up our resources? How do we engage with those in a more community-based way?
Because on your diagram on page 41 of our papers that we talked about before, your starting point is referrals, when in actual fact your starting point is far sooner than referrals. And that's not reflected in this model, and I think perhaps it should be. Priscilla, did you want to come in?
So I've got a comment as well as a question. The comment first of all, I am very much disappointed with this level of report. You've mentioned 3 or 4 times there's a lot of work going in the background. There's a lot of work going in the background. Feel reassured service users are being included, or we are covering it. I'm sure you are, but we're not seeing this. And I can't scrutinise something that I can't see. So you telling me that is being done, with no disrespect to you, I can't see that. Just something that following up on what Chair was saying, in terms of you mentioned single point of access as well earlier on, and then there is further on into the papers, on page 37 forward, I don't know what it is anymore, talking about multiple routes of access, one of them being a website, and then having an initial assessment. Am I to assume that people can do their own assessment or fill out the questions themselves, or is it something that a carer will be doing that for them?
when we talk about the self-referral, we use that term loosely. So, you know, that could be, you know, somebody in the community who's working with an individual who's built up a relationship. They're almost like signposting them into the service rather than a referral. I think we think of referral as kind of a formal process. So people can access it. We want, so within the, you know, the website that we're looking to develop, certainly my aspiration is to have some kind of you know, information as part of that, where an individual can think, oh, you know, that I can access that's there for me. But in terms of any kind of assessments, any formal assessments, that will be done as part of an holistic conversation when they come into contact with the service. So apologies if that's a bit misleading and not clear.
And then just going back, you mentioned about, sorry, I've lost it. Come back. Yeah.
I'll pick up on a couple of questions. Do you want to just turn your mic off while you're looking for it? Thanks. Right, okay, so a couple of questions then. So on page 38, you're saying that for people with long-term conditions and carers, but you don't say about support for carers. So who looks after the person that the carer is caring for while they're accessing these services? So there's nothing in your model that actually leads us to understand what services, will there be any sort of services alongside for a person who needs help that the carer will be looking after, or how does the carer find the time to access service?
Yeah, I mean, it's based on a similar approach already in terms of the Looking After Me service provision, which is specifically for carers. Whilst we won't be providing specific support to look after the people who are being cared for, we would work with an individual how best we can support the needs of a carer within their constraints, within their availability, within their barriers to access the service, have it a bit more flexible. So in terms of getting some one-to-one support, if you like, we want a bit much more flexible approach. In terms of interventions that we design, we need to make sure that they're flexible and people can access those. But it won't be, unfortunately, we won't be providing respite opportunities, if you like, for those people being cared for. And it'll be how we work with existing services and opportunities where that takes place already.
Now, it appears that you're using the same model for people who are carers. That have you established whether that actually works so that as many carers as possible are accessing the service if they need it? Have you actually done any assessment on that? And also you mentioned about mental health and this having a mental health aspect to it, but nowhere in these papers do I see where mental health would come into this. So how are you joining up with mental health in this? Because the services that you mention, you don't mention mental health, but earlier in the paper you've mentioned there be a mental health involvement of some description. So,
Yeah, I mean, in the actual paper itself, I've attempted to answer the query around how it will have a focus around mental and emotional well-being. I appreciate that this operational document might not give as much detail as you obviously looking for in terms of the specifics around that. But at the heart of this model is people's mental and emotional well-being. All the activities in it will be designed to improve people's mental and physical well-being.
well, yeah, I mean, even your model diagram doesn't have an arrow to mental health services. Do you know what I mean? If you're talking about people's emotional mental health well-being to them. There isn't even in your model that you've drawn up, there isn't even a point where somebody would say the mental health issues need to be urgently addressed and we would refer. There isn't even anything in the model that's described. So that's why I'm asking, where's the connections to mental health in all of this?
We take that on board and we will make that more explicit.
And equally, there's no mention of safeguarding. So about empowering volunteers, etc. If there's any safeguarding issues, there's no mention of safeguarding. Okay.
Again, we take that on board. Just a point of clarification as well. A lot of the procedural and operational details, and safeguarding documents will emerge. This is a high-level document.
Appreciate that, but if you're describing your model, all of this should have been encompassed in the model. And also got a question on page 42. Now, you're talking about triage and assessment. Sounds very health related, doesn't it? If somebody is not keen on engaging with health services, triage and assessment is a very health terminology, really. I think, and coach, that's very gym orientated terminology, isn't it, as well? But on page 42, you're saying ensure questions about the whole community are asked to ensure a community-based approach. And my question on this is, how do people know what is in their community? Surely that is something that Community Plus should know, and as part of the assessment, it should be right. Okay, there's this, and this in your community. How would you like to be part of those?
Absolutely, and again, apologies if that's not clear in this document, but that is a key requirement and a key skill of the staff working within the model in terms of their knowledge and their insight. We expect them to have a real understanding of the community that they're working in, the resources and activities.
Okay, because it looks as if you're actually going to ask the person themselves in this text, unless I've read it wrong. So, no.
Yeah, thanks. I'm interested by the assessment being conducted as a conversation and not an interview. Will access to recorded information about an individual be completely open to the individual? There's nothing that's going to be written down that isn't accessible by the individual?
I think we need to, adhere to GDPR rules around data and confidentiality. So, we can't, everything will be available to individuals in terms of any written information, any information that if workers within the wellness model are seeking information from another healthcare professional, it will need the consent of that individual. So we'll follow all those processes and procedures.
Yeah, just to ask about the money. You say that you've determined the envelope, the financial envelope for wellness, which is presumably is that still running from the 1st of April 2019, although the programme's gone backwards? And secondly, what sort of proportion of the budget is Big Life taking?
Just to answer the first question, the budget is from the financial year, so 1st of April. Some of that budget is being used to support the transformation, so to pay for to Big Life. It's only a relatively small amount. It's non-recurrent. We envisage that the support that we get from Big Life is for a 12-month period, and they're with us until September. the reason why there's a bit of narrative there in terms of clarifying the budget, it's not that we didn't know what our overall pot was and we needed to clarify that as such. It's around some of how the existing budget is spent. So on existing services, it's what we call activity-based. So, for example, we commission primary care to deliver smoking cessation, which is activity-based. So that money can go up or down, and sometimes, or what we've realised is some of that money is being spent on prescriptions that's inappropriate. So we can claw that money back and use it better in these services. So it was to unwrap some of that detail really.
Thank you. An observation really rather than a question. I don't want you to try and answer it now. But one of the things that makes it a bit difficult as well for us to fully understand what's happening is we don't have a staffing structure. So we don't quite know whom is doing what. And it's difficult to, in reading the papers, to differentiate within the division of labour. What do coaches do? What is a wellness worker? What about these staff who are being redeployed? You know, is the health visitor doing something? Is a social worker doing? So we can't see who is doing what where, and that really comes down to training. And you know, have you got the people that you need to deliver this?
That's a really good point, and we do have all the staffing structure to hand, and we can provide that information and job descriptions and job roles and that detail of what those workers were doing, so distinguish between the wellness workers and the wellness coaches, and the level of management within the service. So we can provide that. But as you say, absolutely, the staff development and the culture change that is needed, and making sure that we've got the right people with the right values as well as a skill set is absolutely key. And we have been going through that process over the last 12 months. More so, Jill, as the head of service, the staff being transferred into their new roles, they've had to undergo a process of interviews. They've been supported with wider training and development needs to support that change management. So it's at the heart of what we are doing currently, investing in the staff to do this.
And is Big Life just a consultancy, or does it deliver on the ground?
Big Life does deliver on the ground. One of the reasons why we chose them as an organisation is their experience of delivering similar services as to what we've commissioned, albeit their input is more on a consultancy basis for this 12-month period. It's drawing on a range of staff from that organisation with various levels of expertise and experiences, but crucially drawing on their experiences of existing similar services that they currently deliver.
Any further points that anybody wishes to?
Just looking at the proposals in relation to how the service will be targeted, and that based on deprivation figures. Just sort of 3 points on that. First of all, I'm not sure what LSOA stands for. Secondly, the map, which is on page 45, the deprivation map, doesn't actually include the whole of Kirklees. The southern bit's been chopped off. And I just wonder whether there are any areas. So you mentioned Netherton in the text, for example, and I don't think that's actually on the map. So does the southern bit of the map include anything else that we should be aware of? And thirdly, at the top of that page, on page 45, you talk about how services, or an idea about how services might be focused, and you pick out certain areas where the service might be focused. Is that a work in progress? And would there be an intention to actually base staff in those focused areas?
It's all of Kirklees. This service is for the whole of Kirklees. I appreciate that the map is only part of the picture there, so apologies for that. What's been proposed here from Big Life is their rationale is the focus around deprivation. You queried what the LSOA stands for. It stands for Low Super Output Area, which basically means areas measured by deprivation, so geographical areas of a similar population size. So we use that as a measure in terms of identifying our most deprived areas in Kirklees. Yes, yeah. I think it's about 2,500 population size, off the top of my head. What's been depicted here in this map is just part of the picture, really, to show some of those deprived areas. This needs me to go back to Big Life as well and clarify some of this. This is their early thinking in terms of where they feel some of the hotspots are.
Yeah, because when you look at the figures, it's there are the areas they mention, they have high levels of deprivation, but there are other areas that are within the worst 10% as well. But perhaps their figures are slightly lower because of the amount of population that's in those areas. So, are you working across all deprivation areas, or are you just going to work in some deprivation areas? I think that's our key question on that.
I mean, the service is universal. We need to target all deprived areas.
A brilliant idea has just fluttered onto my desk. We need a description of how the service is going to engage with the police, because they have so much contact with vulnerable people.
That's a good suggestion, and we're welcome to working with all key partners to do that. It's something we haven't actually highlighted the police as a key partner, but it's something we need to explore.
Thank you very much. Right, I'm going to draw this to a conclusion then. So I think there's a few things that we've pulled out of this. The outcomes. We've talked about outcomes being in place earlier rather than later, and having those performance indicators and those outcomes more ready for the April end of your work, so that they can be tested during your transition period into September, so that you know whether the service can provide those outcomes by the time you get to September, rather than having them in place in September and then hoping for the best. I think that's perhaps a recommendation that we would want to see. Also, the balance of interaction with people. So yes, absolutely, staff have valuable input into all of this, but you're saying that this is very person-centred approach, and therefore the idea of having a service user panel during your transition period, we would wish to see taken forward, so that you continually have the input from service users on the way forward. Your referrals, I think we need some more clarity, really, that there is a step before referrals as to how that's going to be achieved. The mental health interaction, there's nothing in there. The safeguarding. We also wanted information on the wellness worker and the coach job description. Well, if you want to send us that electronically, we can look at that electronically, okay. And we wanted to know about your user engagement as well, and the interaction with police being form part of the partners that you interact with as well. Is there anything that I've missed there that people think we should be part of the recommendations? No? Alright, so I think probably, would we want to see this back at the end of this transition period before it goes live in September? Yes, to test it out again. All right. So if you could come back before the September, that would be really good. Okay, thank you very much. We will just pause then now before we go on to the next item. Okay, thank you. Very much. We'll now move to item 5, which is the Kirklees Safeguarding Board Adults Board Peer Challenge. You came before with your annual report and we asked you to come back with your peer challenge. They said you would. We've got Mike, the independent chair. Are you going to speak first, Mike? And then can you introduce yourselves as you speak? Thank you.
Button. Okay. Right. Yes. As you said, when we brought the annual report and strategic plan to you last time, mentioned that the Safeguarding Adults Board had commissioned a peer challenge, and we would bring that back here. The important point to make, it was commissioned by the Safeguarding Adults Board, by that strategic partnership. It was not commissioned by the Council, which is the normal practice for peer challenges or peer reviews. And the importance of that is the role of the Safeguarding Board as an independent strategic partnership hosted by the local authority rather than being fully embedded within the local authority. And we were keen that the challenge team that came very much took that view and looked very closely at the operation of the strategic partnership, the cooperation between the partners and the clear focus that the Safeguarding Board has in terms of providing some assurance that those partners were adhering to the principles of safeguarding adults and providing a good service. In a sense, the relationship between the Safeguarding Board and the Scrutiny Board is that we work closely together. We provide perhaps a more in-depth look at services than you would be able to do through these kind of sessions, and so it's important that you feel confident that the Safeguarding Board is doing its job properly. You will see the challenge team. The only comment I'd make about the challenge team is, and it wasn't possible at the time, but some of the peer challenges that I've led and been involved in, we've also had a representative from the police there, and I've found that quite useful. We didn't on this occasion. Okay, we took trouble to meet with the challenge team prior to them coming to make sure that there was a conversation about where the focus of their attention might best be placed. And you'll see in the report I presented to you, I've highlighted that in 113. And these are the areas we wanted to look at. Perhaps the area we were most interested in was how effective we were operating as a strategic partnership and how effectively that was translating into the impact on individuals, and how effective we were in getting that message out there, which actually informed and improved practice. Because we don't run the services ourselves as a strategic partnership, but the constituent members of course do. So we're very interested in what's often described as that golden thread, but that's the last bit of jargon I'm going to use today. We were reassured, in summary, that the findings of the peer challenge, and it was a challenge and it was very thorough, wide interviews, as you'll see from the report, with a range of constituent partners and individuals. There was little that came out of it that was a surprise. However, we don't want to be complacent. We have our work programme. We brought that to you last time in the annual report and the strategic plan. I've spoken to colleagues since the report came in. I don't particularly want to see a separate improvement plan around the
a peer challenge. What I want to see is us to start to revisit our existing plan and make sure that we make adjustments and improvements to take account of the findings of the peer challenge team. I think that's important because you can easily get lost in lots of different plans, and we don't need to do that. What we need to do is take fully account of it. I've highlighted in the report because I think it's an important thing to share with you. The golden thread, I said that was last time I'm going to use it, but the golden thread needs strengthening. We do need to make sure that all those things that we receive assurance about are actually stronger than they currently are. And one of the actions we've already decided to take as a safeguarding board with the expertise that sits within the safeguarding unit and indeed with the board members is to get greater engagement with frontline practitioners. We do it already through our newsletter, we do it already through network events that take place twice a year, and they are really popular, the network events. You can get over 100 people involved in one of those. But we think there is a place now to have some practitioner forums separately. And as a board, we are keen to take responsibility for facilitating some of that and providing some expertise into those forums as well. I think I should stop talking because you'll no doubt have questions on the report itself and respond to those.
Hello, my name's Alison Monroe. My question relates to your to the partners who are involved in relation to how they are regulated, who regulates them, who checks they're adhering to your the policies that are of the board, and how do you know that they are compliant with your policies?
I think it's important to describe the infrastructure that we've built around the board. Prior to my tenure, you didn't have an independent chair. You've got an independent chair now. And one of the things that I was very keen to do was make sure there was equal partnership in terms of making sure the board run effectively. I need to just take you through this. It's quite important. So, for example, the board is a strategic partnership, but it needs an engine room behind it to do the work. So we have an engine room, we call it the delivery group, and it is chaired by a director of nursing. We have subgroups who deliver the work programme, and we make sure those subgroups are chaired by the partners. For example, the Safeguarding Adults Review subgroup is chaired by the police. And we took a lot of trouble to talk to our partners about their engagement at all levels in the process. Now, partners then bring to the board or to the delivery group, the engine room more than the board, to be honest, their performance reports in terms of how they are delivering and adhering to the principles of safeguarding and the responsibilities of safeguarding adults. And the dashboard that we have is being developed to be much more inclusive in terms of their performance, health performance in particular. So we now receive, as part of our dashboard, information about serious incidents in NHS settings, and we start to interrogate those through the subgroups, through the delivery group, and ultimately when the reports are brought to the board. So whilst we don't run the services as a board, we've put in place methods for starting to get that information. That is new. Most boards struggle, and I know boards elsewhere, struggle to get information beyond what's the statutory return to the Department of Health, which tends to be social care data. We are moving beyond that, and we're starting to get health data now. And that's not always understood by our health colleagues, the need for that, but I think we've got there now.
So I'm sorry, I'm still confused. So who effectively regulates them then? Are you saying that basically?
We're not a regulator. We're not a regulator. NHS organisations have their own regulator, the Care Quality Commission. Yeah. We're not a regulator. Yeah.
Got a question on your outcomes page for people who use services. So it's page 9 of your report, page 56 of ours. Page 9 of your report and page of the Peer Challenge report and page 56 of our papers. So it's outcomes for and the experiences of people who use services. In the areas for consideration, the first 2 bullet points both refer to users. The first one about the use of a voice being heard at board, and the second one on evaluating the outcome and impact of the work with people who use services. I just wondered what ideas you have for looking at those 2 issues.
We have had for some time on the board 2 lay members, and part of their responsibility was to help us with some of that. But we have 1 lay member at the moment, and we've had a serious thought about how we move forward on this particular issue. So with the support of our existing lay member and our Health Watch member, we are developing approaches which will involve 2 things. One is the development of some kind of reference group of users by experience that can support the board. We haven't got there yet, but it's on our work programme, and I think I mentioned it last time when I brought the annual report. And the other is, and our Health Watch colleague has offered to help us with this, is to start to introduce board meetings with some live stories, some real examples of how people have experienced a safeguarding intervention. And some of those stories will be good news stories, and some of them will have learning attached to them. Now that will be new for us, but that's something we're going to introduce this year. It's quite difficult. We also are introducing surveys of people who've been users by experience. Believe it or not, GDPR is an issue for us there, because in order to contact those people, we have to have permission to contact those people. So if you look at historical cases or cases that have already started, there is a bit of difficulty until we can, and we don't particularly want to intervene and say, can we talk to you later on at the wrong stage because people are going through something. But once the system is well established, of course people will be asked right at the outset. But GDPR has positive and unforeseen consequences sometimes.
And just on the second point on the evaluation?
We do file audits regularly through the board, as does Richard and his managers as well. We are working hard now on turning our engagement strategy into a communication and engagement strategy, which I think is an important part of evaluating outcomes. And we're further developing the work, as I said, on the use of questionnaires with people who've been part of the process. So the evaluation of outcomes is always a challenge. The bit in the report I think you'll see is that the safeguarding paperwork that practitioners have to fill in requires them to put something in about outcomes as well. So it's possible to see the practitioner's evaluation of the outcome in relation to their discussion with the people that they've been supporting. So there's a fair amount of evidence there, but it doesn't necessarily, in a formalised way, come to the board as strongly as we'd like yet, but it's there.
So does that pick up on the practitioner's view as such rather than necessarily the user view?
think what we're talking about is one of the real challenges about how you very directly hear the voice of individuals, but at an aggregated level. So the data does tell us a bit about the outcomes for the individual when you aggregate them up and look at, say there were 100 instances of 100 people, what were the board level outcomes, so you can pick out themes. I think then the real challenge is almost how you get the free text comments of those 100 people and are able to do something with that in the aggregate rather than looking at each of the 100 to pick out either kind of themes that emerge from that. And some of that thematic work is done because we understand patterns about areas of risk in terms of where abuse might take place, the outcomes for individuals in terms of the extent to which things were resolved and how they were resolved. But it's almost that, I suspect it's about how did the process feel for individuals as much as what was the final outcome. It's that how did the process feel bit, which I think is the bit that's difficult for a board to capture because you need to be able to kind of look at that across 100 cases.
Have you previously done in-depth audits, so on random audits? So would it be something that you could look at service user experience using that type of model?
Thank you, Chair. Yes, so Mike previously talked about, sorry, I should say I'm Saf Boot, I'm the Head of Safeguarding and Quality in Adult Social Care. Mike previously talked about the structure of the board and the subgroups. One of the subgroups is the Quality and Performance subgroup, and that's a multi-agency subgroup which I chair. And we met only last week, and it was really interesting to see how the principle of making safeguarding personal, so that's all about the meaningful and proportionate conversation with individuals, is now better than it ever has been. So there are specific questions in the paperwork that practitioners use that tries to tease out and supports that conversation, which is outcome based. So there's emerging evidence there that is now sort of being used, being embedded. The use of advocacy and the support offered to people also is higher than it has been before. And then in the context of file audits and assuring ourselves that these things are being embedded, the Quality and Performance subgroup and the board has a quality assurance framework, and there are a number of principles or lenses through which we ask specific questions to help with our assurance. So we try and get a sense of quantity. So we're looking at some of the numbers in terms of safeguarding concerns and notifications that come in through the system. We ask questions around quality, so some of the things that I've talked about. Are we having the right conversation? Is the response, the safeguarding response, timely? Is it effective? And that's continuing to improve. And then ultimately it's the so what? What does it mean to the individual? What impact has it had? Has it reduced the risk? Is it managing that risk well to the individual? And again, through those meaningful conversations, through some of the questions that we ask around the management of risk, that's beginning to emerge through a whole set of intelligence such as case file audits, surveys, questionnaires, staff feedback, etc.
Come back to something that was raised a bit earlier, Mike, with when Alison asked you a question earlier. I really just wondered how, given that it polices itself and investigates its own complaints, I wondered how accessible the NHS is to yourselves.
Yes. I can't answer for the NHS arrangements for dealing with complaints, but I can say that we are now able to interrogate where we see preponderance of serious incidents, and how we can start to ask questions about are there particular hotspots, particular hospitals, particular wards, particular GP areas that are throwing up unusual preponderance of issues, and we can start to interrogate that. We don't interrogate their complaints.
No, sorry, I mean, I knew you didn't, but the interest in Access was that it's an organisation that marks its own homework, and I wondered if the things you're really concerned about, if you get to be able to see them.
I don't want to make a comment about how the NHS marks its own homework, but I do think we have here a very strong partnership. I think there's no merit in hiding things. There's a lot of merit in dealing with things, and that's the culture that we adopt, and that level of transparency is really important. We've tried to create a safeguarding board which is very outward facing and very prepared to accept criticism, if you like, as a learning tool. That's the philosophy we take. I do believe that the NHS partners on the board are open. The board has a culture about people are free to talk in the board and free to share, and they're free to share in a way that we problem solve. There's a kind of cabinet responsibility, so I don't expect board members to go and say something different to what we've agreed in the board, but we do want people in the board to feel free to challenge, to criticise, to share difficulties and problems. I don't believe the NHS is hiding a lot from the board. I do think the NHS had a bit of struggle to start with in understanding why we were wanting to add a certain amount of their data to our, I'm being honest with you, to our dashboard. As I said, I think we got through that now. It's not about finding fault, it's just about understanding what's happening within that constituent area of our work.
Yeah, I think we all have experience of trying to get hold of data from the NHS. Are there any other points, Priscilla, did you want to come?
Is it just, have you been dealing with 28 cases through the year? Is that correct? Is the caseload, or is that just been for this particular department? Shall I grasp how many cases you're actually dealing with? And actually what kind of outcomes come through after that?
The board itself does not deal with cases. The local authority does with the partners, the NHS and the police, depending on the level of seriousness. The case file audit that's undertaken by the Peer Challenge looks at a number of cases in depth for us. Yeah, and that is not the only time those case file audits take place. So routinely case file audits are undertaken. So managers do randomly read cases, including Richard, to look at cases and sort of see how they think people are performing. The intelligence that's derived from that process may well lead us into a themed audit. So, for example, if there's a preponderance of questions about whether the Mental Capacity Act is being effectively applied, then it's more than likely, well, it's almost certain we would do a themed audit then on Mental Capacity Act.
Can we ask about the gap that seems to be there from the peer review between the board and operational staff, and the confidence of operational staff across board partners, and the need for upskilling in the safeguarding area. So how are you looking to address that gap that has been identified and the lack of confidence that seems to come through that operational staff have in making referrals, etc.?
I don't want to belittle the peer challenge, because that was a genuine thing that was said, but you know, I know it is based on some of the interviews they did and some statements that were made by individuals within focus groups. I think it is an issue we have to address. I'm not sure it's an issue of the magnitude that perhaps comes across in the report, but I don't want to belittle it at all. We have to deal with it. The main areas we have at the moment for engaging with frontline staff are around network events which have themes attached to them. So, for example, we'll have one around self-neglect, we have some around dignity and care. We have various ways we do these network events of making safeguarding personal. We have that, and we have somebody who produces an excellent newsletter with information. It's really important that one of the things that we need to, when we do, ask our constituent partners to do is to make sure that there is time for teams to actually have time to consider learning from the information that comes out through the newsletter or things people read about the network or other training events. But as I said earlier on, I think the main thing that we feel we might do better to tackle some of this is to have practitioner forums. And we would expect those practitioner forums to be run by the service, but we would be there to facilitate and support those forums.
Thank you, Chair. Yeah, just to add to that, I think there's a role for board members here as well. So board members recognising their role in sort of taking some of those core messages back into the organisation, ensuring that those conversations are being had at the team or frontline level. Also to echo Mike's point about collaboration, so some of the core issues, some of the more complex and cross-cutting issues can't be done in isolation. So I think part of it is recognising that there are a number of services, a number of functions both within and external to the council where we need to find ways in which we can collaborate. So colleagues are doing quite a lot of work in sort of doing staff briefings or frontline staff sessions on things like modern day slavery, which I've previously brought to scrutiny also, and domestic abuse. So I think it's just continuing to have that dialogue through a number of mechanisms, and that could include comms, but also offering staff the opportunity through briefings, through network events, etc., to hear about the work of the board and the contributions that frontline staff can make.
Can I ask as well then about the increase in volunteer network? Because if operational staff are not feeling confident in how they would handle a referral or what information they needed or what questions they would be asking, there is an increase in volunteers in Kirklees. Now, if those volunteers work alongside staff members, then there's a structure there. If they don't, then there's no structure there. So how are the board looking at how volunteers can be skilled, as well as operational staff can be skilled to be able to feel able to make referrals if they feel it should be needed?
Just to respond to the operational staff aspect of the question there, Chair. So one of the things that certainly we're doing in the Council is promoting the message that safeguarding is everybody's business. And we recognise that over the years, perhaps it's become somewhat of a technical response for safeguarding. So everyone has a role to play, and we launched that as a message a couple of months back at one of our senior management group meetings that the Chief Exec opened up. And it's partly recognising that everyone has a role to play. The system absolutely is inherently complex in terms of how you respond. But equipping staff, and we call it the eyes and ears, so equipping frontline staff, people who are out there, and people particularly sort of supporting vulnerable people and in our kind of place or street scene type services, equipping them with the knowledge and awareness that they require so that they can begin to sort of spot the early signs, and if there are questions, they can start to talk to the right people. And what that doesn't mean, and we're conscious of, is that there's an influx of activity that's then reported into the safeguarding board or the safeguarding system that the local authority hosts. What it does mean is that key managers across the organisation, who are the sort of designated leads for safeguarding, are equipped with the knowledge and the understanding of what they should do if their staff approach them with concerns around safeguarding or risk. So that piece of work, certainly in the Council and looking at operationally, has kicked off, and it's ongoing, and I look forward to coming back and sort of presenting that back to the scrutiny panel also at some stage. Carl Battersby is the exec lead on that work.
you're right. There's something, and the point the staff has made is being really clear about what the expectation is on people. And so we have people out working in adults and children's social care who need to be experts in safeguarding. There's something then about a curiosity, which is everything about frontline staff. It's our volunteers working in the library. We saw that through some of the campaign material on modern-day slavery, which is just getting people to be curious, and if they have a concern, to not to have to be concerned they need to investigate that, but to have the confidence that they know who they can just flag that with. So part of the induction programme, for instance, for volunteers working in libraries is that precise that bit about if you see or hear something that is of a concern, you don't need to kind of resolve it per se. Just go and talk to a member of staff, and they will then pick that up and manage that on your behalf. So it's a very basic awareness raising, and indeed it's no different to the role of 69 elected members who are out and about in their communities have in terms of being curious. You will hear things when you're out and about, and it's having that confidence that that doesn't feel quite right. I don't need to solve it, I just need to know who I can talk to about it.
That answers the question as to volunteers who work in a structured service. But as the last item, there'll be more interaction with volunteer groups that don't run within a structured service. And so if your operational staff are having concerns, then how are you going to give the volunteer networks that are not directly connected with service the confidence to say, right, okay, we need to ring somebody up here and just pass this information along?
Although this peer challenge report is positive, although it tells you you've got a good board and it tells you you've got good services out there for adults, it tells you all of that, it makes a number of recommendations, and you've picked up one of them, about that we can never be complacent, we've always got to move forward. One of the areas that I talked about was how we are going to move to a position that, rather than have what might be seen as a bit tokenistic, relying on lay members, we want to move to a position that we have greater interaction with the voluntary sector, with users by experience, etc., etc. Our idea is to develop a reference group to help us to do that, and we have Healthwatch on board helping us to do that. The other area is, as the chair of the board, I get invited to go and meet with the meetings of third sector leaders, which is voluntary sector organisations. So I have a slot there where I talk to them about exactly the point you're making, how you can really be seen as a very strong resource. Many of those organisations now have safeguarding champions and dignity champions within their structures. So there's almost an informal network beginning to develop there. But this is a nut that I suggest, not being pessimistic, will never be fully cracked. There'll always be people that say, I don't know what to do, I don't know how to do it, all the rest of it. But we are doing a lot in Kirklees to spread that message and really get that out there and identify those champions who are not part of the statutory services, who can start to help with some of that, because it's not always about being alongside a practitioner, it's being alongside somebody who knows what to do.
Were there any more questions on this area? So I think we picked up, didn't we, how to engage more with the service users' experience, and maybe having, well, you said you aggregate up, but having that ability to actually deeper dive randomly into and get that information on the service users' experience. And also you said about not having a new plan but having an existing plan and embedding that. And further work on your network events and your practitioner forums and everything. So could it be that when you come October time with your annual report, you'd have had 6 months then for the board to have looked at all of this, that maybe as part of that annual report review, we could also have an update on where you are with this particular piece of work.
I think that's inevitable, Chair, because the advantage of embedding these kind of points within our existing work programme is that we will, by default, be reporting back to you on those points.
Including as well, I think we haven't picked it, but there's a comment about more work between the adults and children's safeguarding and the transitions.
Can I just make a comment on that? Because this afternoon we're meeting with the chairs and officers involved with the Children's Board and with the Community Safety Partnership. And the purpose of that is to re-energise the work that started a little while ago around collaboration between the boards, and this is the kind of outward-facing stuff. And of course, it's based on the principle that we're all interested in the same thing, health, well-being and safety of the community in different ways. So we have a meeting this afternoon to put together an agenda for the next formal meeting, of which you'll be interested. The other thing, of course, is very keen, if I could get it minuted here, the way in which the boards have collaborated and done members' briefings in the past. We'd like to see that continue. We think that's hugely valuable. It links with the point staff made about helping members identify the role they have in supporting this work as well.
Okay, thank you very much for that. Right, the next item on our agenda is the review of the work programme. Okay, so page 79 then, financial position of the Kirklees Health and Adult Social Care Economy. They're coming back in June. I think we have this on a regular basis, and they're hopefully coming back in June to talk to us. Okay. Kirklees Health and Wellbeing Plan and the work emerging from West Yorkshire and Harrogate Healthcare Partnership. Do we think that that's an ongoing piece of work? Yes? Yeah? Integration of health and adult social care, another ongoing piece of work because we're far from there yet, aren't we? CQC inspections, that's an awareness of what's happening that we need to do. Quality of care in Kirklees, that's CQC coming to talk to us, and they'll be coming in April to talk to us again. Suicide prevention, we're still waiting for some updates on that, but there was a piece of work that was highlighted on health services for men in the 45 to 60 age group, be discussed at a future panel meeting. So we need to bring that forward on the work plan. Podiatry services, are we satisfied that that's in place? That piece of work is finished? Yeah, finished now. Mental health transformation programme, well, I think that goes with the piece of work that we're waiting for on rehabilitation and recovery services. We're waiting for a model on that. So probably that can be joined together because it's that model on that new service that we're waiting information on. We're also trying to organise visits to CHFT, as mentioned there. Wheelchair services, are we content with that, or would we want maybe an update, a written update maybe as to where they are after the contract, and then we can have a look to see where they are after the contract has been in place. Okay. Adult care offer consultation, we've done that. I think that's been gone. The adults safeguarding board, that's the regular item that comes, and diabetes in Kirklees. I think we said that's probably. I think we've had that a few times now, haven't we? So we'll just transforming outpatient care. That again is a visit that we want to see. Ambulatory care. That is. To be followed up, so that will continue, and then the rest are just follow-ups. The fetal alcohol syndrome, of course, we're waiting for the West Yorkshire. That's been taken up on a West Yorkshire level as we recommended, and we're waiting for some feedback on that. Okay. And also we'll be looking at ambulance response times. So we've got some information on ambulance response times across Kirklees, and so we'll be putting that on the work plan, yes, to have a look at in more detail. Okay. All right. Anything else at this point in time that you wanted to mention?
Whether we could have a look into the single point of contact with local, the actual first initial contact stage, not about the actual services after, but the actual, how they're managing to do that.
Do we want to expand that slightly to all single point of contacts in Kirklees and how they interact with one another and how people know which single point of contact to go to? Peter?
Yes, I think that would be a good idea. But I think we probably need to have, on the locale theme, we need to look at care closer to home as well, please. I do take the point that the single point of contact.
Yes, and we've got a single point of assessment in today's papers as well. But yes, care closer to home needs to be on the work plan, as GP networks as well. Do we want GP networks on the work plan as well? All right, okay. So if there's any further items that we think we might want to look at for the work plan, we can discuss that in April as well. All right, thank you. Oh, did you want to bring in
I'm just going to ask about the conflict of interest paper, but I've got to page 14 so far. I just wondered whether we will look at any of that.
We did have some information that came in on Friday, didn't we, following an information that we'd asked for previously. I think we need to have a proper look at it and then see where we take that next. Okay, so we can discuss that again at the meeting in April. All right, and the next meeting is the 9th of April. Thank you very much.